So the objectives of this video is to review atrial fibrillation, its risk factors, its pathophysiology, its negative consequences, and overall our treatment priorities in the pre-hospital setting. Obviously, that is all dependent on, is atrial fibrillation the primary cause, or is it a secondary cause? Like, is this patient experiencing sepsis that's leading them to go into atrial fibrillation, which we saw in the second case study. Ultimately, we will apply the knowledge here to the case studies and differentiate how these two different patients need different treatment priorities. So if we look at some facts about atrial fibrillation, it's the most common arrhythmia that patients will experience. Obviously, as we get older, the increased risk of atrial fibrillation goes up. Approximately 17% of 80-year-olds will experience atrial fibrillation, and the lifetime risk of getting it is 25%. So literally 1 out of every 4 people are experiencing atrial fibrillation in their lifetime, which is quite absurd. And that's quite depressing to think about. So how does that apply to paramedics? That means we will see it in the pre-hospital setting. We all know that if we spend time on the road, everyone seems to be like they're in atrial fibrillation. It can lead to negative consequences, and we could provide some different therapies and treatments based on their circumstances. So to apply what atrial fibrillation is and how it occurs, it's always good to overview what's normal. Because if we have our heart here, we obviously know conduction should come from the SA node, travels down into the AV node, goes to the bundle branches, and gets dispersed out by the Purkinje fibers. So that's why it leads to a regular rhythm. Impulses should be uniform. They should be synchronous. It's coming from the same spot. Hopefully the SA node going down the same route. That's why it's regular. That's why you have a P wave. That's why you have a normal PR interval, narrow QRS. This is why it's considered a normal sinus rhythm. And it should be between 60 to 99 beats per minute, with obviously some individual variability. If you're athletes, your heart rates could be slower, of course, at resting. But again, this is normal sinus rhythm because of those factors. In comparison, if we look at somebody in atrial fibrillation, you have somebody with rapid and uncoordinated atrial contractions. So you can see all these kind of multiple ectopic foci going on in the atria. This is kind of analogous to ventricular fibrillation. You have multiple ectopic foci going on in the ventricles that leads to the ventricles to quiver. In comparison to atrial fibrillation, the atria are physically contracting not sufficiently, and it leads to this quivering because the atria can actually fire 300 to 500 beats per minute, which is insanely quick. And a reason why it's so irregular, because only some of those impulses will get through the AV node down to the ventricles. But this could lead to a fast ventricular response from atrial fibrillation, leading to rapid AFib, which can be a problematic rate related problem, and over 48 hours can lead to increased risk of clots. So if we see overall, atrial fibrillation can lead to this rapid uncoordinated atrial contractions, and this is when it manifests on the ECG. So any rhythm that has irregular R to R waves, you have no identifiable P waves, and usually has a narrow QRS with some exceptions, such as Wolff-Parkinson-White syndrome, you're in an atrial fibrillation. Again, the most common arrhythmia. However, patients can be in a rapid atrial fibrillation if it's over 100 beats per minute. And this can be a rate-related problem, again, usually in the first 48 hours. After that, it leads to increased risk of clots. So if we distinguish between the causes, obviously the greatest risk factors for atrial fibrillation is cardiovascular disease. Number one subset of that is hypertension. Hypertension is so problematic for so many different risk factors: strokes, heart disease. Every day you have untreated hypertension that kills and destroys your nephrons, and those are irreplaceable. So this extends to so many different things, and this is why managing blood pressure is so important. But this can lead to increased risk of atrial fibrillation. Coronary disease, previous heart surgery, valvular disease can all heighten someone's risk. So obviously this applies when we ask their medical history and you're trying to establish, is this a new onset AFib? Like, what are your risk factors? How old are you? Have you had previous heart surgery? Do you have mitral valve stenosis? All these things can increase someone's risk. However, we can also look at non-cardiac causes. So a pulmonary embolism can lead to atrial fibrillation. The inverse of that is atrial fibrillation, specifically rapid atrial fibrillation over 48 hours, can increase the risk of pulmonary embolism as well. Excessive alcohol can lead to somebody going to rapid atrial fibrillation or just atrial fibrillation. It's called holiday heart, and we'll get into the reasons why. COPD can lead to AFib, sleep apnea, stroke, hyperthyroidism, and obviously there's genetic components, increased risk of age again, and overall, all these different factors can lead to it. So when we look at impulses, again, the impulse should come from the SA node, go down to the AV node, goes down through the bundle branches, and subsequently the Purkinje fibers. It's uniform, it's synchronous. In comparison, in rapid atrial fibrillation, you can have that re-entry pattern, which we discussed in the previous module. In addition, it can lead to this multiple wavelets, so you can have multiple different impulses traveling around the atria, again, potentially going at 300 to 500 beats per minute, leading to the atria to not contract appropriately. It's uncoordinated, it's dysynchronous, and this leads to the atria quivering. And only some impulses get through to the AV node down to the ventricles, and that's why it can be so irregular. And again, if you look, multiple wavelets, so this is kind of the same as ventricular fibrillation. When you have all these multiple wavelets in the ventricles, you can actually see them quivering. The difference between atrial fibrillations, obviously we still have a pulse being generated from the ventricles because they're still contracting despite being intermittent impulses. When ventricular fibrillation happens, it leads to quivering of our main pumping chambers, and that does not create a pulse. So that's the difference. And obviously the risk of atrial fibrillation causing strokes is high. It's interesting that ischemic strokes is actually the major cause of strokes or patients when they experience strokes. If somebody experiences a stroke or embolic stroke, that can be caused by atrial fibrillation approximately 25% of the time. And the worst thing about it is strokes caused by AFib are usually more severe. They have a sudden onset of symptoms, and they usually have an increased risk of mortality. Specifically, they have a twice as high mortality in comparison to other types of strokes, and it's usually more devastating consequences. So if we look, usually clots are formed on the left side of the heart, usually in the left atrium and around the left atrial appendage, which is here. Because again, if the atria aren't contracting appropriately and fully, this leads to the atria quivering, but it leads to blood stasis. And blood stasis creates this conducive environment for clots to form. And the problem with clots forming, what if little pieces break off? Then they travel subsequently around the body. Because we know the left side of the heart distributes blood around the body. So imagine these pieces of clot go and include a large vessel in our brain. Or they go into our leg, cause a deep vein thrombosis. And it can also lead to venous thromboemboli. So all this can lead to so many negative consequences. What if it gets large in a large vessel in our kidneys, our intestines, our legs again? This can lead to devastating damage. So think about turning on your hose, you put a marble in the hose that includes the water, and now water can't travel distal to that, and that's your artery in your brain, and you deprived any blood flow and sufficient oxygen distal to that area. And we know our brain's the most metabolically active organ in our body for the most part. It takes 16% of our cardiac output, and it utilizes 20% of our oxygen. If you deprive that by any degree less than what our homeostasis should have, you're going to cause irreversible damage if the blood flow is not restored. So that's why clots can be created. And again, usually the timeline is less than 48 hours. It's a rate-related problem. Over 48 hours, it's an increased risk of thromboemboli. But sometimes it's hard to distinguish because a large percentage of patients, usually around a third, are actually asymptomatic. So it's truly hard to develop a timeline if you can't distinguish they developed onset of symptoms then. So the significant problem with atrial fibrillation causing strokes, it usually includes large vessels, specifically the middle cerebral artery. And that supplies blood flow to a significant portion of our brain. And that's why it applies to when patients get strokes from atrial fibrillation, they're usually abrupt. You have this massive onset of symptoms, and it can lead to critical damage in a very prompt timeline. Because look, if we look at the middle cerebral artery, it supplies all this brain area. So imagine you have disruption to this significant portion of your brain. that can lead to devastating consequences. Because here's the actual MCA here. Look how it supplies all these indispensable areas. And obviously, depending on the size of the clot, how much blood flow's been deprived, how long has it been going on, it can lead to different clinical manifestations. It can have unilateral weakness or numbness, facial droop, speech deficits, which could be leading to mild dysarthria and aphasia to overall global aphasia. So it's all depending on those factors. But again, 20 to 25% of all strokes are caused by atrial fibrillation, and they're usually more devastating. So that's obviously why we do ECGs in the pre-hospital setting for patients suffering from stroke to see, is this caused by atrial fibrillation? And again, if we dissect more of the mechanism that leads to increased risk of strokes, atrial fibrillation obviously causes contractile dysfunction, and that leads to that blood stasis again. Because the reason why atria can't contract is inherent in the mechanisms that lead to atrial fibrillation. Because in atrial fibrillation, you get the structural remodeling. Basically means the atria are disfigured. They change in the shape and the size, and this can lead to increased risk of atrial fibrillation. And just the inherent nature of how those changes occur, it increases the risk of blood stasis and thromboembolism. Because imagine you have long-standing cardiovascular disease, hypertension, or you've had mitral valve stenosis. That leads to a deprivation of oxygen and blood flow. And obviously that can lead to dead cells. Also, what if you have heart failure? All these increased risk of cardiovascular factors. That can lead to dead cells, but the body tries to heal itself. So it releases fibroblasts, which are cells that the body releases to create connective tissue. So overall, it's like those cells are dead. I'm trying to replace them to create connective tissue, so they release fibroblasts. However, that leads to fibrosis in your atria. And this disrupts our cardiac action potential. It can slow impulses. It can speed up the refractory periods. And obviously, if you have structural damage, it can lead to electrical disruption as well, because those two go hand in hand. And this can all be exacerbated by atherosclerosis, again, fibrosis, impaired myocardial function from an MI or previous MI. What if you had cerebral small vessel occlusions? All these can lead to increased risk of structural changes in our heart that can exacerbate one another. But for someone to go into atrial fibrillation, they need something that leads to this trigger for ectopy, which means a abnormal heart rhythm. And the reasons why this happens, we look very microscopically, again, can be you have these multiple wavelet reentry theories. So you have these different impulses traveling at different waves that leads to the atria kind of contracting uncoordinated, but leads to contractile dysfunction. And if you look at like very microscopically again, it's usually a disruption in our calcium levels, because you have this calcium overload in our cells, and specifically the little area of our cells that kind of houses the calcium, our sarcoplasmic reticulum, actually releases calcium. And when this happens, it disrupts our cardiac action potential. It actually shortens our refractory period. Refractory period, no matter the strength of the stimuli, it will not produce another action potential if you're in the absolute refractory period. However, if we have a strong enough stimuli, it may produce another action potential in the relative refractory period. But again, this shortens that time, so you're more likely to respond to other stimuli if you shorten your relative and absolute refractory periods. So this is why it can lead to tachyarrhythmias and rapid AFib, because obviously this can affect our cardiac action potential. And the reason, or if you look, if calcium overloads the cell, that can lead to myocardial damage. It disrupts our contractile kind of tissues and integrity. And this can all heighten the risk of people going into atrial fibrillation, because it leads to structural disruption and electrical disruption as well. And again, if you look at this, it has tissue heterogeneity. So you have different types of tissue and different types of action potentials because of the damage that occurs in patients suffering from atrial fibrillation, or risk factors that lead to people going to atrial fibrillation. Because atrial fibrillation tissue tissues that's been affected conducts faster because of shorter refractory periods. And when we look at the increased risk of clotting in patients in atrial fibrillation, again, they're in heightened risk for thromboemboli, venous thromboemboli, deep vein thrombosis. They do have an increased risk of pulmonary embolisms. However, clots normally form on the left side of the heart, so it's going to get distributed to the systemic circulation, in contrast to the clots forming on the right side of the heart, which would get included in our lung capillaries, and it can't travel through the capillaries, so it lead to a pulmonary embolism. But you have something called Virchow's triad, which can be attributable to other coagulation problems, such as a pulmonary embolism. Overall, you need something that leads to hypercoagulability. You have abnormal blood flow, and you have vessel wall abnormalities. So all these have to intertwine to lead to an increased risk of coagulation and the formation of a thrombus or thrombi. So hypercoagulability means you have this activation of clotting cascade, and that happens in atrial fibrillation patients. Now, obviously, we know there's an abnormal blood flow. If your atria are contracting at 300 to 500 beats per minute, that leads to blood stasis. And patients will obviously have vessel wall abnormalities because of endocardial injury and atrial fibrosis. Because again, if you've had issues that lead to the death of myocytes, and we're going to release those fibroblasts to replace them to rebuild it with connective tissue, but that leads to atrial fibrosis, that can increase the risk of vessel wall abnormalities, that increases our risk of clot formation. In addition, this can be exacerbated by inflammation. And this can overall lead to atrial enlargement. What happens is that the body releases fibroblasts to try to create this connective tissue to replace the dead cells. But in consequence, it leads to these very fibrotic atria that can change our structural integrity. And this overall leads to atrial dilation. Because if you have any disease or risk factor that increases the size of our atria, that can heighten your risk of atrial fibrillation. For example, one of our case studies, the patient had mitral valve stenosis and a history of congestive heart failure. Blood isn't going through the valve, or you have a problem with the left side of your heart. You cannot function as a pump on the left side of your heart, which is the left ventricle's main function. Blood essentially backs up into the pulmonary circulation and into the atria as well. And this leads to increased pressure, because the more volume you have in a chamber, that enlarges your pressure as well. So to compensate for that, your atria will actually dilate because of this rise in atrial pressure. And again, this can happen in valvular disease and heart failure. And overall, this increases the risk of atrial fibrillation because it disrupts our structure of our heart, as well as disrupts our electrical conduction. So those two go hand in hand. So we look at the clinical manifestations. Patients have a reduction in cardiac output. And usually the most common symptoms of patients in atrial fibrillation is fatigue and dyspnea. However, again, patients could be asymptomatic approximately a third of the time. But the reason why they could be so fatigued and short of breath, and they can also experience dizziness, weakness, some palpitations, and chest pressure, is because it overall reduces our cardiac output. It increases our myocardial workload. Under normal healthy circumstances, the atria supply 20% of our blood volume because of that atrial kick. But in atrial fibrillation, you don't have that ability to do it. So your cardiac output gets potentially dropped 20 to 25%, which is substantial. So that's why patients get so short of breath. They feel fatigued because they're not getting enough oxygen and blood flow because of these reasons. And overall, you're increasing the workload of your heart because the impulse is so irregular. You've lost your atrial kick and such a fast heart rate. So overall, these can all lead to these clinical manifestations, which we saw in our first patient. So the patient in the second case study was experiencing sepsis. So this is relevant because patients can be categorized as in primary atrial fibrillation or secondary. Primary fib, it's like you're in atrial fibrillation. What are your clinical manifestations? Are you stable versus unstable? Because if you're unstable, which is evident that you're hypotensive, you've got pulmonary congestion or crackles, you're cyanotic, you're mottled, you have an altered level of consciousness, you have ongoing chest pain, or a combination of all those clinical manifestations. Truly, it's not advisable for ACPs to cardiovert in the pre-hospital setting atrial fibrillation because there's increased risk of strokes. It's hard to establish timelines. There's so many different factors that doctors have to assess. It's like, how old are you? What type of disease do you have? Do you have a history of valvular disease? Are you on anticoagulation? Have you been compliant? All these different factors. That's why it's typically reserved for those patients truly unstable. And if you don't do this, there's an increased risk of death and morbidity. And that's why it's beneficial to just transport them to the hospital so that they can assess all these risk factors and reduce the chance of patients having a thrombus created post-cardioversion. However, sepsis patients can go into atrial fibrillation because of sepsis. Because obviously in sepsis, you have deprivation of oxygen. You can have this dysregulated immune response, and overall this leads to systemic complications. This patient had a pneumonia. So obviously that leads and disrupts your oxygenation, and the atria are so sensitive to any lack of oxygen. So this can lead to ectopy, which means abnormal impulses. And this is why they can lead to this uncoordinated atrial contractions. This is also exacerbated by this increase of catecholamines, epi, norepinephrine. And those get released in sepsis to compensate for the insult. So that's why you can see tachycardias. It helps rise our blood sugars. And overall, it can increase ectopy in our cells of our heart that increases this abnormal atrial contractions and this dysregulated nature of it. And if we look at holiday heart too, excessive alcohol can specifically deprive us, and we lose a lot of magnesium, potassium, and also you have this rise in catecholamines as well when we excessively drink. But if you lose electrolytes, that obviously impairs our cardiac action potential, and this can lead to increase in ectopy as well. So that's why patients can go into atrial fibrillation and why it's called holiday heart. And we know from previous modules, we have our beta-1 receptors, which are found in the kidneys as well as the heart. And we look more specifically, beta-1 receptors on the SA node and the AV node. So if you have all this excess catecholamines stimulating this can increase inotropy and chronotropy, but eventually you could have so much catecholamines, it leads to increase in ectopy, and this is why they can go into atrial fibrillation. Overall, it makes sense to treat somebody that's septic with fluids and other supportive therapy, and this is why they get vasopressors potentially in the hospital setting depending on their clinical circumstances, because it wouldn't make sense to cardiovert them because you haven't fixed the underlying cause. They could actually do worse if you cardiovert them before you actually treat their underlying cause, so that's why it's a secondary atrial fibrillation instead of a primary. Overall, this video is to overview the risk factors, the pathophysiology, different circumstances, apply it to the case studies, and kind of guide our treatments. Again, the timeline is important because under 48 hours, it's a rate-related problem. Over 48 hours, it's an increased risk of clots. But sometimes it's hard to distinguish a timeline because, again, a third of patients could be asymptomatic. We will see this in the pre-hospital setting. It's the most common arrhythmia. And overall, so many different risk factors can lead to atrial fibrillation. And different pathologies can lead to atrial fibrillation as well. And this is why they're intertwined, and they can all increase the risk of strokes as well. We know atherosclerosis increases the risk of strokes. We know hypertension increases the risk of strokes. We know drinking, excessively drinking, increases the risk of strokes. But overall, atrial fibrillation is an independent risk factor for strokes as well, and other thromboembolic disease. So it's a complicated pathology we'll see in the pre-hospital setting, many different causes, and we have different treatment options. Again, for ACPs, atrial fibrillation should not be cardioverted in the pre-hospital setting unless they're truly, truly unstable, because there is an increased risk of clots, specifically with different risk factors as well, and this should be done and examined by a physician in the hospital setting.